juvenile onset diabetic with poor circulation and diabetic neuropathy. As you can see, these are diabetic ulcers with lymphedema and evidence of gangrene. Questions?
Any osteomyelitis?
None apparent, although not definitive.
Treatment?
To stabilize the blood sugar, consider antibiotics, possibly amputation.
What's her name? I was just wondering the patient's name.
More than 20 years ago, Dr. Stephen Barrett crossed paths with Dr. Lee Dillon. He is known for pioneering and improving the modern field of peripheral nerve surgery. Dr. Dillon is a retired professor of plastic surgery and neurosurgery at Johns Hopkins University and the founder of Dillon Institutes for Peripheral Nerve Surgery. Dr. Dillon made the very astute observation in the early 1980s that most, if not all, of the symptoms of diabetic peripheral neuropathy in the extremities were due to nerve entrapment. That one incredibly random chance event when Dr. Barrett met him and learned about this discovery changed everything for him.
When I first learned that many of the symptoms of diabetic peripheral neuropathy could be reversed by nerve decompression surgery, I was skeptical, needless to say. But I was fortunate because I got to see patients in Dr. Dillon's office that had had previous nerve decompression surgery, and they related great improvements in sensation and reduction in pain.
Extreme pain, burning, needles in my feet.
Back in my room that night at the Inn of the Colonnades, I couldn't sleep. Many thoughts were going through my mind about what I had seen that day in Dr. Dillon's clinic. The first question was, why didn't anyone know about this? Why isn't it being taught in medical schools? The second question was, how can I get a hold of the patients that I had told there was nothing that could be done for them that suffered from diabetic peripheral neuropathy for the last 15 years?
These early 90s, Lee Dillon speak at a meeting called New Cardiovascular Horizons, and he spoke about nerve decompressions and diabetic neuropathy with superimposed nerve compression injuries. And I went up and talked to him and said, I don't think that makes any sense. And in his gentle way, he explained to me that I didn't know what I was talking about either after he asked me a few questions and invited me to come visit him, which I did. And then that led to taking some coursework with him, and it kind of opened, when I saw the evidence that was being presented, even at that early stage, that opened my eyes to that possibility, and then I began to practice it.
And very grateful that I had that opportunity, and that just totally revolutionized my practice. It's never been the same since. And so that was approximately 14 years ago. Very skeptical at first when I learned about the fact that we may be able to reverse the symptoms of neuropathy, but started doing these procedures and started to see the amazing positive effects it's having to my patients. It would just totally have a very major impact on their life.
The question is, why, with all of the solid medical evidence that we have today regarding nerve decompression surgery, is this not adopted by mainstream medicine, where so many lives could be dramatically improved and many saved?
That question is the purpose of this documentary.
By having knowledge about this surgery, it will allow you to give someone, perhaps even yourself, one of the greatest gifts of all, the relief of suffering.
Diabetic neuropathies,
What's called neuropathy.
Diabetic neuropathy.
Diabetic peripheral neuropathy.
Diabetic peripheral neuropathy.
The neuropathy is a metabolic difficulty. We do know how biochemically it can affect the nerves, because when you have high glucose levels, you use different pathways to manage the sugars that are in your blood. So the hexokinase pathway is one that results in accumulation within the nerve trunk of a sugar alcohol called sorbitol.
Diabetes is a disease that involves the whole nervous system.
Even though diabetic peripheral neuropathy is a very complex situation, the actuality is that in many cases, it's a problem of a swollen nerve in a tight tunnel.
A lot of these people, I call them the silent sufferers. I mean, neuropathy very commonly will present with the burning, the tingling, and the pain, and those are emotional. Those are the symptoms that keep you awake. Those are the emotions that drive you to be on drugs, maybe even narcotics.
And the patient is so important. You can't dismiss their symptoms that they have.
The patients not only had balance and gait issues, but they had pain issues, and the pain drives those patients more than the numbness and the weakness.
And right now, there are probably about 30 million or so, 31 million people with diabetes in the United States. About half of these patients have some form of what's called neuropathy, or the loss of protective sensation. And some of those patients have some degree of painful neuropathy as well.
About 2% of people who aren't diabetics have a pinched nerve here. About 15% of diabetics have a pinched nerve here. And if you're a diabetic and your feet are involved so that you have diabetic neuropathy, 1/3 have compressed nerve in their hand.
Certainly knowing that 85% of amputations are preceded by an ulceration or an open wound. If you can avoid that open wound, that ought to decrease amputations, and decreasing the amputations ought to give you a better opportunity for a longer life.
And so what happens is, when someone develops neuropathy, they can lose what one of my mentors used to call the gift of pain, and they can literally wear a hole in their foot, like you or I'd wear a hole in a sock or a shoe. That hole is called an ulcer, a diabetic foot ulcer, or a wound. About half the time that wound gets infected over its natural course, and that's why there's an amputation every 20 seconds somewhere around the world. And that's an amputation that we think hopefully can be preventable. And I think that's why we're having this talk now.
This means that while you watch this documentary, nearly 3,000 feet and legs will be amputated. Once you lose a foot or leg to amputation, you have a 7 in 10 chance of not surviving 5 more years. Wound care is very expensive and extensive. More than $1 million is spent every 30 minutes in the treatment of the diabetic foot complication. Most of the time, this is due to diabetic peripheral neuropathy.
The wound care clinic costs are in the neighborhood of $15,000 to $25,000 per occurrence. Now, if you go on to become one of those 10% of people with a diabetic foot ulcer who are going to require an amputation of a toe, foot, lower leg, or upper leg to heal up your infected leg, then the costs rise to $40,000 to $80,000. So it's an extreme extremely expensive event for the healthcare system as well as for you and your own pocket.
I've been a paramedic for the last 30 years. They tried different kinds of meds, amitriptyline, I'm on Cymbalta and Lyrica now. I've really found nothing that will help the pain except minor relief.
One of the ways of distinguishing between a simple model of nerve compression and a disease where the nerve axon itself is involved is that if you think of my finger as the axon and the myelin formed by the Schwann cell around the axon, when you have an underlying disease that affects the nerve itself, the axon is said to dwindle or shrink or die back, and it's worse farther down on the leg and not so much, say, up in the thigh. And the myelin stays pretty thick or sort of normal in the beginning. But when nerve compression is added to that, the myelin becomes thinner. So with nerve compression, you see thinning of the myelin, and with an underlying disease like diabetes, you have the axon in trouble. It isn't until the axon gets really fairly far along in terms of being sick that its interaction with the Schwann cell causes the myelin to change.
And this has been demonstrated repeatedly. The best way and the most accepted way is that ultrasound measurement of the cross-sectional area of the nerve is about 25% larger when you're diabetic, and it's a little bit bigger in the diabetic neuropathy than it is in the diabetic without neuropathy. Interesting fact, don't know why that happens. But time after time people have been able to demonstrate that the swollen nerve is a marker for diabetic neuropathy. Well, that's fine if the fat nerve has a place to be fat, but there are certain places in the body at or around joints where the body is constructed to guide the pathway through which the nerve travels.
One of the components of diabetic neuropathy, and there are several, there's certainly microvascular disease, but when we're talking about diabetic peripheral sensory neuropathy, we do know that the nerves produce this chemical called sorbitol, and sorbitol, roughly speaking, is what's produced when we're in a state of dehydration, and it makes our body hang on to all the water that it can. Sorbitol produced in the nerves makes these nerves hang on to all this water. All this water floods the nerves, and it makes the nerves then swell. These nerves have to go through anatomically narrow areas every time they cross a joint, and sometimes even away from joints. When they go from the spinal cord out to the periphery, there are narrow tunnels they have to go through. And we know, everybody's heard of carpal tunnel. That's one of those narrow tunnels. Well, it turns out there are narrow tunnels in the lower extremity too, and so when they go through these narrow tunnels, they fit perfectly before the nerve started to swell. But when the nerve swells, all of a sudden they don't fit in those tunnels anymore, and they don't glide through those tunnels, and so they become compressed. And it's much like if you have a ring on your finger and you have a hand injury and your hand swells. They may have to cut the ring off your finger in order to save your finger, because it'll cut off the blood supply to your finger. The swelling of the nerve cuts off some of the blood supply when it goes through these narrow tunnels to that nerve, and the nerve becomes damaged.
I think if you control things systemically, and you've ruled that out, then I think treating people distally, where the problem is when it's going around a corner, and decompressing that can be a promising adjunct.
Collated that information, it hasn't been published yet, but the same findings are true, that the true stocking distribution just doesn't exist in diabetic peripheral neuropathy. Some nerves are spared, some nerves are damaged.
Is whenever there's a compression in a tunnel of a nerve, and I would argue that because the nerve is sick, in diabetes, whenever you have a compression, the nerve will get sicker and sicker fairly quickly.
In diabetic neuropathy. Now, even the skeptics about what we do say there can be individual nerve entrapments. So the neurologists and the endocrinologists say, yes, that can happen, and the proper treatment of it is surgery. But what they are not able to come to understand is that you can get a whole suite of entrapments. You can get 4 entrapments in that lower leg, and that will produce the picture that they classically describe as stocking glove anesthesia in the lower extremity. That can also be produced not just by a length-dependent axonopathy, which they believe in, but also by multiple peripheral nerve entrapments. One of the problems with the nerve decompression divide, where people who do it and see the results are wonderfully enthusiastic, and the people who've never seen an open, fat diabetic nerve with a dent in it from a compression at a fibroosseous tunnel, who are very skeptical of it, that's the problem. And the people who've never seen it want to have level 1 evidence. And part of the reason is that it requires a change in paradigm for those skeptical people to say, oh yeah, I guess I had it wrong. And changes in paradigm are very hard to accomplish.
If a nerve doesn't have a known site of entrapment and you have a metabolic process going on that's swollen nerves and all of the other tunnels, and they're all affected, then you can pretty well conclude that it's due to superimposed nerve compression and not just some axonopathy from the metabolic disease. So that's the whole premise behind nerve decompression in patients with diabetic peripheral neuropathy. You're not operating on neuropathy, you're operating on nerves that are pinched. That's really important.
2003 was the time that I had the triple decompression, but the superficial fibular nerve was not addressed at that time, and I've had minor ongoing aggravations, which I have laid at the presumed that it was because of continuing entrapment of the superficial peroneal and fibular nerve. And those compressed nerves are the ones that we aim for and we relieve by making more room for them, just by opening the fibrous part of that fibroosseous tunnel. So you've got a fat nerve, but now it's happy. And that's what we're really doing with nerve decompression for diabetic neuropathy. We aren't doing anything about the neuropathy. You still have neuropathy, but you don't have the compressed nerves that causes the pain, that steals your sensibility and sensation, and that allows the development of these terrible diabetic foot complications.
I was introduced to the Medtronic intraoperative nerve monitor, the NIM, and how it was used for ear, nose, and throat procedures, and then whole body procedures, including lower limb nerve decompression. But in terms of blood flow, the blood flow can be restored very quickly, and the surgeons in the surgery suite, you can see the color of the nerve improve within seconds. And the same thing is happening with the large vessels, because in these tunnels you have a nerve, you have an artery, and you have a vein. So when you release and they can be pressing on the blood vessels as well. So when you decompress the nerve, you're also decompressing the blood vessels. So the flow in the large vessels are also improving.
If the nerve is going through a narrow tunnel, and which would cause swelling, then decompression of that tunnel will release the nerve or liberate the nerve and cause the circulation to the nerve to be reestablished, and therefore whatever pain or symptoms like weakness that are affecting the muscle or the nerve as a result of that will basically get rid of this compression, and the nerve will regain normal function.
But most likely it's the group of diabetics who were born with tight medial and lateral plantar tunnels, tight calcaneal tunnel, an extra fibrous band underneath the peroneus longus, thick fascia covering this, where their anatomy combined with the susceptibility of the diabetic nerve give them these symptoms.
I was asked to go observe a case where they were using the Medtronic nerve monitor to see if the nerve function changed at all after the decompression surgery. So they were monitoring the nerve, they were recording from the nerve both before and immediately after decompressing the nerve, releasing the nerve. And what I saw was a huge increase in the amplitude of the muscle activity. So the muscle activity just jumped through the roof immediately after decompression. And I would not have believed it if I didn't see it. In fact, I didn't believe it going into this. The senior director of marketing at Medtronic explained what they were doing, and I said, well, so they're treating a nerve that has been compressed for maybe 10 years, maybe 20 years, and then they're releasing the compression from the nerve, and the nerve gets better right away. And the marketing director said yes. And I said, I hate to tell you this, but that's impossible. That doesn't happen. So when I went to the case, when I saw the surgeon, and he showed me the results with the nerve monitor intraoperatively, the patient was still anesthetized. So there's no bias, there's no placebo effect possibility. I was just scratching my head, and I just couldn't understand how this could happen. And I had to, on the trip back from that clinic, on the plane, I thought, I thought I understood peripheral nerves. I really don't. And it was from that point that I started working with the Association of Extremity Nerve Surgeons to learn more about what they're doing and to try to help generate a possible mechanism of action on why this would work.
Well, basically, you're irritating or impairing the nerves at two levels. With high blood sugars and the toxins that produces, the nerves that are furthest from where the part of the cell that creates those proteins lives, which is up near the spinal column, all the way down into the feet, you're impairing that part of the nerve that's way down towards the foot. If you, on top of that, compress the nerve, which is where those molecules are being transferred from upstream to downstream, you're going to slow that down further. So it makes sense that if you open up the stream, so to speak, of the reparative molecules being produced up here that are going down to the foot to help them repair themselves, you're going to make it better.
Jerry Long again. You had your right leg done in April. How's it feeling?
A lot better.
Okay.
A lot better feeling, less pain.
More movement?
Yes.
Okay. The color even looks much better in it. So we're going to go take you back here in just a minute for your second surgery on your left side.
Be glad to get it done.
All right. I think you told me you were looking forward to getting out of pain the last visit.
Yes.
Or last time we...
Getting getting where I can do a lot more.
Yeah.
Yes.
I think that that some of the data in the literature, it really is guiding us to show that there may be some promise.
The results that we get with unentrapping peripheral nerves is not only remarkable, it ties in with other evidences in medical practice that if you can identify a nerve entrapment anywhere in the body or a nerve pressure, you get somewhere. Certainly the best example that the public could relate to is carpal tunnel syndrome. I mean, carpal tunnel that's shown to have fibrosis, scarring, and entrapment, you can release that, save a hand. And what you're doing is you're saving a foot, you're saving a leg, you're saving ambulation, and above all for the patient, they're probably more happy to get their pain relieved than their ulcer healed or prevented. But it does work, and it's such a simple concept that I think we need billboards on the highway that says, look for entrapment. You can better yourself. Okay? No, we need an entrapment hunt. We don't need any more evidence. We've got plenty of evidence. We know it works. End of discussion.
And it kind of opened, when I saw the evidence that was being presented, even at that early stage, that opened my eyes to that possibility, and then I began to practice it.
I have seen patients with nerve relief and decompression with much better outcomes than patients who have suffered long duration of compression. So basically, I base my recommendation for treatment of patients on the fact that I have EMG evidence of nerve compression.
That's such a wonderful thing that you can demonstrate with electrophysiology EMG testing that within the time it takes you to switch from operating to recording the signals of a muscle, which is 60 or 90 seconds, within that time, in most cases, you can have a large improvement in the EMG value. And that's true. What we were working on was in particular the peroneal nerve at the knee, but the tibial nerve and its entrapments at the medial ankle and the bottom of the foot also. And sometimes these improvements were not only immediate within 2 minutes, but also they were in size of 400 or 500% improvements, sounding things. And the neurophysiologists and nerve PhDs that we've been working with on these things are just flabbergasted that this is the kind of improvement that can be demonstrated.
We just have had some great successes in diabetes and restoration of sensation in the plantar feet. That has been unbelievable. And to see, do I have any one? No, there's a whole bunch of them, but to see the look on the patient's eyes in the recovery room when you can pull their bandage down a little bit and tickle the bottom of their foot and they start crying and they sit there and tell you that they haven't felt that in 20 years, and then you feel the other foot that hasn't been operated on and they can't feel it. This is not placebo effect.
And the most important thing is, just before we met you, I could not walk without the walker. I had to use the walker. And it was really painful also, because I could not live my normal life, right? And plus the pain itself. Now, not only my as I said, like sugar levels are down, I'm away from my walker, I'm not using cane, I can walk on my own, and then plus I can drive by myself, maybe an hour or two.
That we are finding in the operating room that there is a measurable difference in nerve function. And the exciting thing is that I was noticing this for some time.
I think that the data that has been presented up until this point is promising and is really, in some cases, tantalizing. I think that to show that something like this at scale can make a difference is going to be important.
I started doing this surgery in 1982, and by 1989, there were about 50 patients I'd operated on, and 80% of them were better. So that makes 5 separate independent basic science laboratories have shown that this works. And to the best anybody knows, there is no placebo effect in animals.
you can always counter every argument with a simple fact. I think there's power in that.
Medicine is a very conservative field. It took a very long time for people to accept that you should take aspirin to try to prevent heart attacks. It took a very, very long time for people to understand that penicillin was actually useful. And medicine should be conservative. The things we do in terms of drugs and surgical procedures affect people's lives and can have complications, and we want to be sure that we respect our primary duty as physicians, which is to do no harm.
And I pride myself in educating my patients so well, because I tell them, once you leave our practice, you're probably not going to hear this. So I have to arm you with information.
It actually made more sense than anything I've ever heard another physician tell me or anything. So
I had never seen anybody with it. It wasn't part of my training in med school or residency, and it was certainly not part of my referral pattern. If people got it severe enough and I wasn't able to take care of it, I would refer them to neurology or sometimes our vascular folks here, and but usually they would end up coming back without any more relief than they'd achieved earlier.
I'm afraid that the really widespread acceptance is going to take training a new generation of physicians, and because they will have to hear it. There are just too many of us as medical professionals that quit learning after we finished our training. But if the people with neuropathy, if the people with diabetes pound the table, that's the thing that would accelerate that. But it's probably going to be a process that takes 5 to 15 years from the time we have these level 1 evidences out there.
Sometimes when there's a belief in medicine, and you know this from being a paramedic, that it's hard to get rid of that belief because once it's trained, it becomes ingrained.
Yeah.
One of the problems with some of the medical profession is I think they stop thinking when they leave training, and it's the unusual person who is saying, what I'm seeing in front of me doesn't really make sense. And that's kind of the way it was with me in this nerve decompression business. I saw Dellon, he looked at my feet, said, certainly you have diabetic neuropathy. And so he operated on one foot, and then another 3 months later, and I found that it partially reversed the sensory loss, did a marvelous job of relieving the discomfort, and we went ahead from that point with him inviting me to be involved with the people, mostly podiatrists, that he had trained in his techniques and ideas. So I've been involved with that group for almost 15 years now, and my involvement has been looking at some of the problems that nerve decompression can address.
Well, I think in general, people look at diabetic neuropathy starting off in the lower extremities particularly, and then kind of moving up. And by the time it gets to, say, the middle thigh, then it starts getting up into the areas of the upper extremities. So neurologists that do a lot of the electrophysiologic testing really focus more so on the upper extremities and less so on the lower extremities. And I think everyone has been a little bit nihilistic about the lower extremities in general. And I think people like Dr. Dellon and others like yourself have been able to show that you can decompress nerves down here just as well as the upper extremities. But I think in part it's because neurologists and physiatrists who do EMG nerve conduction study testing tend to focus more so in the upper extremities and are less interested in lower extremities, and that's true for orthopedics as well.
The profit is in medications, chronic medication, but resolving chronic disease, or with your procedure, resolving key sequelae of the disease, that just means, you know, business is lost. So you can almost understand, it's like a competitive threat, and businesses instinctively work against competitive threats. They lobby, they do research that's biased, they influence doctors' education in a certain direction, and it's not really a crime, it's protecting business, but it causes huge suffering. So in a roundabout way, it is a crime.
It's just, it's wrong it's misinformation, it's wrong information, and the information's out there that this does work, but there is a sea of antagonistic behavior to shift the dialogue away from what we do, to say, no, that doesn't work, either from the pharmaceutical industries or for other groups that don't have a vested interest in listening to what we have to say.
The point is, so Dave knows how to do this work. He and the chief of plastic surgery went to visit this neurologist.
Okay.
The neurologist told them, quote, over her dead body, would a diabetic ever have a nerve decompression in there at the University of Michigan Hospital?
Oh, we need to get that. That's what we need. Right. Okay, that's
it's such a fascinating, he would probably be able to be interviewed because he's going to be younger than her, and he's not going to be, he just has this brand new paper, 2018.
Okay.
And his review shows that on ultrasound you can see changes. It has all Scott Nickerson's papers, which are objective. It has even papers with electrical testing that show improvements. But he still finds something wrong with everything, you know. Even though he says all these really good things that have been improved, he still comes out finding, of course, something wrong.
Before my colleague and I, who was a vascular surgeon, received our cease and desist letter from the CEO of our hospital, I went to get my mail one day in the physician lounge early in the morning before doing rounds, and it was full of colleagues of multiple specialties. And I saw that our neurologist was in there who was leading the bandwagon against this work, and I went up and I said, is there any particular reason why you're preventing roadblocks for my colleague and I for performing these work on diabetic patients? And he looked at me and he pointed his finger at me and he said, I am here to protect the public from people like you. And pretty interesting, when we had been friends up until that point, for him to take that viewpoint against us. And we had a cordial leaving after the meeting, but it was evident that there was a significant polarization in the neurology community against the surgery community, whether it be vascular surgeons or myself performing this work.
We know that 1 out of 6 diabetics will have an ulcer, and going on, 1 out of 6 of those people will have an amputation. That the type of surgery that is nerve decompression will reduce or prevent ulceration and amputation, prevent admission to the hospital for foot infections. And these are objective outcomes. They're not placebo in any way as an effect. You either do or don't have an ulcer, you do or do not have an amputation, you did or didn't get admitted to a hospital for a foot infection.
It's really difficult, and there are examples, studies where new medical paradigms generally take 20 or 25 years to really become normal or normalized, so it's a real problem. And if you have the industry disliking a paradigm, then you can add a lot to that.
So I think if you're smart, you have to take the best of all of these, the highly controlled studies, the clinical series, logical clinical index cases and extrapolate it into patient treatments. You have to take all of the best of those. You can't just say, we're not going to do this, we're not going to pay for it if it's only this quality of research. And if that quality of research can't be done in this particular disorder, then you're never going to get that quality of research, and medicine will stay stuck because of a technicality, a statistical regulatory process, as opposed to taking the best of clinical experience, case series, and actual clinical research and publications, because there's a lot of information out there that is not published, but is very good information. It's part of what you pass on as part of the practice of clinical medicine.
diabetic population who's suffering with these painful problems needs to know that something is available. And just in the last couple of years, we have a really strong scientific study that has established that.
Across the board in diabetic and non-diabetic patients, the results that we see from this work are absolutely life-changing in patients. It has changed more lives. I do a lot of work in the leprosy field, and when you look in the Cochrane reviews, they go, well, decompression surgery or neuroplasty in the hand and leg isn't really good, but we have a program that we run where we do complete decompressions of all the nerves at the tunnels, and the 14-year follow-ups with these people, we've given them their function back, restoration of sensation, restoration of power to the muscles, and elimination of pain.
Stop a suicide, I mean, what greater reward can that be for a doctor?
We're not going to beat the medical profession into shape, so we need to appeal to the people and have a grassroots demand rise.
A year ago, I was happy just to have a few minutes of relief from pain. The doctors, Dr. Jensen and everybody I see, had got to the end of their treatments, and pain management was what they wanted. Pain management isn't what I wanted though. From February to now has been a 100% reversal. We just got back from Disney. We finished the surgeries in July, but November just got back from Disney. Got to take my grandkids down and enjoy the parks and everything like a normal person.
The people with diabetes and neuropathies pound their fist on the table and say, here's something that works. You got to do this for me, Doc. And that's what I think we can be hopeful that getting information out in methods such as this can be very helpful.
Might just finished with one kind of soundbite. When you described to me the procedure and how elegant it was to remove the material around the nerve and physically fix the problem, which is pretty long-term success. But then if you combine that with switching the type 2 diabetic person to a low-carb diet with proper support and coaching, that synergy will be utterly life-changing. Pain gone, burning gone, and metabolic health returning, neurological health, depression lifting, altogether completely life-changing.
The greatest gift of all, the relief of suffering.